translation section. Remember, we're having simultaneous interpretation today. And so please go ahead and look across the bottom section of the Zoom toolbar and select the language that you prefer. All right, we already have some folks who are already sending greetings and putting names in the chat. I encourage you to do so. I think we are ready to begin.
Yes, we are ready.
Perfect, thank you. Welcome everyone to the Washington Healthcare Facilities Community of Practice webinar event that is focused on advancing equity and ensuring gender responsive WASH in all healthcare facilities. My name is Joanne McGriff, and I am faculty within the Center for Global Safe Water, Sanitation, and Hygiene here at Emory University, and I am joined by members of our Community of Practice Facilitation team, Lindsay Denny, as well as Haley Elling. Yes, there he goes, waving there. Today, we're happy to have several really great guests from UNICEF, WHO Southeast Asia Regional Office, White Ribbon Alliance, as well as Ghana Health Services, who are really going to help us move this conversation forward. So I'm really excited about having them join us. This is just a reminder slide that we have for all of us to sort of be on the same page in terms of what this community practice is and what we're about. Just to remind everyone that we are an action-oriented learning platform that brings together the WASH and the health communities to focus on policy, evidence, and practice in WASH and healthcare facilities. Our objectives are threefold. You see them. We use the words connect, share, and act because we really do want to connect partners and colleagues in the WASH and health community who are really interested in moving along in terms of action in the WASH and healthcare facilities. We also provide this platform as well as other elements, whether it's our newsletter, and we'll talk a little bit about the webpage that we have for the community of practice to share experiences, ideas, best practices. And then finally, we encourage everyone, individuals and groups, to take specific action to implement sustainable interventions that improve WASH in healthcare facilities globally. So whether you are new to this platform or you are an expert, you're the colleagues that we've worked with for so many years, everyone here is welcome. And we just, again, encourage you, if you haven't already, to go ahead and start putting, I see them still coming in, your name, where you're from, and certainly your greetings in the chat. I have one more slide I want to go over in terms of our foundational principles. And really, again, just reminding everyone that the perspective that we take as we work on WASH in healthcare facilities and have our discussions is that WASH is a fundamental prerequisite for quality care within a healthcare facility, and that there cannot be effective infection prevention and control without adequate WASH. WASH in healthcare facilities is also a solvable issue, and that we know that it will require multiple systems, sectors, stakeholders, collaborators, partners to work together to see sustainable improvements. And then, of course, as I just mentioned, this community of practice is open to all who seek to learn, share, provide context about WASH in healthcare facilities, and we welcome and respect the diversity of perspectives that we know will participate. Next slide. So this here is our success corner. Every time we meet, we're going to try to make sure we bring to you something good that's going on in WASH and healthcare facilities. And this is also a reminder slide for me to make sure that all of you are receiving the newsletter that we send out. We try to send out at least one newsletter a month just to get everybody onto the same page and share information that we're receiving, post new studies, and certainly we will include a success story. And this is the success story that was included in our very first newsletter earlier, actually just last month. This was World Vision Zambia, and this was a water system at a health post that had been without access. And then through the Citizen Voice Action Group, community members took on an initiative to construct a maternity ward that will expand space to meet the growing demand for services. And then World Vision then connected the water system to this new maternity annex and constructed the septic tank and soakaway. Again, all successes are good successes for us to talk about. So I do encourage you, if you have projects, really good stories that you would like to share with us, we encourage you to go ahead and email us or send it through the listserv WNHCFaction@emory.edu, and we'll be happy to feature your successes in the field as well. Next slide. Also, each time we come together, we're going to give you as much as we can in terms of the most up-to-date resources or, again, news that we have. And in this context, we're really happy to announce, not so much announce, but share with you that the Ministry of Health and Medical Services in Fiji has just published guidelines for Washington healthcare facilities. And this is really what's spectacular. It has a specific focus on climate resilience. And this is really one of the first guidelines to do so. So we were really excited to hear about this, and certainly very grateful to our colleagues in Fiji who were willing to share sort of the title and where this exists. And you can find this on the washingtonhcf.org/resources website. And please go ahead and look at this, as many of us, probably all of us, need to be thinking about climate resilience as it relates to Washington healthcare facility infrastructure, as well as even some of the training and software components. So with that, I will take a pause here. And I see we have many participants coming on. Again, we ask you to make sure that you have selected your preferred language through the translation icon across the bottom so that you can listen in and listen to the simultaneous interpretation that's going on right now. And I will pass it over to Haley to move us through the next part of our presentation.
Wonderful. Thank you, Joanne. I'm going to share my screen quickly. So hopefully you can see a full screen. Yes?
Yes, you are ready to go.
Yep. Good to go. Wonderful. Well, thank you for that, and welcome everyone. My name is Haley Elling, and I am a WASH program manager with World Vision, and I am very excited to talk to you all today about gender responsive WASH in healthcare facilities and give a brief introduction before we dive into the later half of the agenda today. But the overarching question is, why do we need to consider gender, and specifically, why gender responsive WASH in healthcare facilities? And essentially it's because poor WASH service provision disproportionately affects women and girls. And this and inadequate WASH services in healthcare facilities can lead to so many negative health impacts for women and girls, including increased maternal mortality rates, the risk for poor reproductive health, acquiring healthcare-acquired infections, and specifically WASH facilities and healthcare facilities in low and middle income countries fail to provide user-friendly and gender-sensitive services. So either they fail to provide gender-segregated toilets or menstrual hygiene management services. And common challenges associated with this include that women feel unsafe in toilets and bathrooms because there might be a lack of gender-separated facilities. Perhaps the bathroom doors cannot be locked, so lack of privacy, the infrastructure, or sometimes there's just a lack of lighting. Oftentimes soap and water is not available for hand washing, and the hospital environment can be unclean, whether that's due to open defecation or perhaps poor cleaning services or poor cleaning practices. A lack of area to bathe after giving birth for either the mother and the newborn, and then also a lack of menstrual hygiene management. And all of these items are crucially important that we recognize the importance and the need for gender responsive WASH in healthcare facilities. And to provide a definition of gender responsive WASH in healthcare facilities, largely it examines the gender inequities and opportunities within WASH programming, engaging female stakeholders throughout the process and addressing needs specific to women. So within the healthcare facility setting, there are multiple perspectives that can be considered. I'm going to touch on three. So the first one is female patients, so including mothers, female healthcare workers, and then female leadership. So first, addressing female patients. Female patients are particularly vulnerable in healthcare facilities, just largely because they are more frequent visitors to the healthcare facility and due to the nature of delivery and childbirth. So major wash concerns that impact women, specifically when there are poor wash conditions, include dirty, contaminated delivery settings. Sometimes there's an inability to wash themselves or their newborn after birth. There's a lack of private, safe bathing and sanitation facilities. And in addition to this, if toilets are not next to post-delivery rooms, sometimes women are unable to manage or address their postpartum bleeding or menstrual hygiene management. And then some specific health realities and concerns that result because of this are poor management of both the menstrual hygiene management and postpartum bleeding, but also incontinence and the risk for fibroids and endometriosis. So because of this, because of these inadequate wash services in healthcare facilities, it's not just dangerous for women, girls, and newborns, but it also can lead to overall patient dissatisfaction and can prevent women from using the healthcare facility and can cause complete changes in care-seeking behavior. So interviews from recently delivered women in Uttar Pradesh in India found that the cleanliness of toilets was reported as a common concern in the majority of healthcare facilities. And oftentimes women would refrain from using the toilets due to either irregular supply of water, lack of proper cleaning, the unavailability of soap, and then specifically related to maternal health services, poor wash provision in healthcare facilities was the reason women chose home delivery. So alternately seeking different areas for behavior, not actively seeking the healthcare facilities for delivery and childbirth. And in 2018, a review suggested that improving wash conditions in healthcare facilities will decrease patient dissatisfaction and increase care-seeking behaviors, improving health outcomes. So it's not just important, obviously talking about their health and safety is important, but it's also specifically focusing on what women are asking for. And so because of this, we have, you'll hear later from Christy Cade on this call, but the White Ribbon Alliance in 2018 conducted the What Women Want survey to go to the source and to ask women specifically what they wanted related to their quality reproductive and maternal care. So they surveyed 1.2 million women across 114 different countries. And as then their global results found that WASH was the second highest demand reported by women, just behind the first demand, which was compassionate and dignified care. And as you can see, this photo is a photo of a woman holding up what her demands are. So she demands water, toilets, and more beds. So this demonstrates that not only is WASH needed in healthcare facilities, but it's demanded by women across the world. You know, they want to see healthcare facilities that have WASH, that have accessible sanitation, where they can come and they can have a clean birthing and delivery experience. The second perspective is that of the female healthcare worker. So the lack of adequate WASH in healthcare facility puts female staff at increased risk of healthcare associated infections and undermines their safety, motivation, and ability to do their job in a clean and safe environment. Seeing as 75% of the global health workforce are made up of women, they need to be able to have these WASH facilities within the healthcare facility. And the lack of gender separated toilets dedicated to staff increases the risk of UTIs from health workers because they're physically holding in their urine during their shifts. In addition, not having safe private locations for changing used menstrual materials can lead to anxiety and stress, and can reduce concentration and productivity throughout the day. And then also some women just miss entire hours or entire days of work to avoid managing their menstruation in difficult environments. You know, because women make up such a large percentage of the healthcare workforce, they need to be able to have these services. They need to be able to use a sink to wash their hands to provide safe quality of care. And the last perspective I'm going to touch on is female leadership. So as I mentioned, approximately 75% of the healthcare workforce is female. However, the majority of leadership positions within the healthcare facility, both at the facility level and within the Ministry of Health, are held by men. And so this can cause big power dynamics between the female frontline healthcare workers and male health leaders, which can lead to further prevention of women from being involved in the decision-making and the resource allocation process. And this also can affect everyone's ability within the healthcare facility to address gender-specific WASH needs. And this leadership gap, this gendered leadership gap, is a huge barrier to reaching the SDGs and universal care. And it is crucially important when we think about, who is coming up with these decisions, who is in the room when we're making decisions, and who are these decisions affecting. It's really important that we have not only women, but a diverse group of people making these decisions and providing the insight to have these services. So finally, some examples of strategies for gender responsive WASH in healthcare facilities. The first one is to ensure that women are a part of the WASH in healthcare facility strategy, design, planning, and monitoring process. And not only as patients, but as leaders, health workers, and community members. Reviewing gender disaggregated data for WASH in healthcare facilities, and then including gender specific indicators for WASH services in healthcare facilities. Supporting the government in setting minimum standards for gender responsive WASH in healthcare facility. Considering women-centered design principles, so encompassing women in every approach of the design area, and supporting training for healthcare providers, cleaners, and other healthcare facility staff. And I'll just put a plug for cleaners here, that women make up a huge percentage of the workforce of cleaners, and oftentimes they need to be aware of different cleaning areas and requirements, and how these requirements have different set standards of cleanliness in different areas, including different standards in maternity wards, the surgical theaters, and things like that. And then taking a page out of the White Ribbon Alliance book and going to the source and asking women what they want. So with that, the key takeaways, I don't know if this slide is I'm supposed to do, or I'm supposed to hand this over back to you, Joanne, but I'll just say them because I'm here. So the key takeaways, so the key takeaways from this brief introduction is that female patients, and particularly mothers and female healthcare workers, face specific challenges in healthcare facilities that lack appropriate WASH services. And inadequate WASH in healthcare facilities can increase the health risks of women and their babies, and can be a deterrent to women utilizing health services, and can alter care-seeking behaviors. Female healthcare workers make up 3/4, so 75% of the global healthcare workforce, but power dynamics prevent women from decision-making and resource allocation roles. And integrating female perspective in the design, planning, and implementation of WASH in healthcare facility programs is essential to addressing these challenges. So with that, I will hand it back over to you. And off you go, Joanne, to talk about ways that we can get involved.
Thank you so much, Haley, and such an excellent job to give us sort of that really important overview and just giving us the foundation as we move forward to talk with our panelists and guests as it relates to gender responsive WASH. So thank you so much for that. And as I will say that all of the slides and this recording will be available to you after this session. We do have a webpage that we're going to show you where all of our materials now are going to live, so that if you miss something, or if you want to take your time and go over some of the facts and really great information that Haley just shared, or look at some of the information we shared from the launch about 2 months ago, then you're going to be able to review all that on our archive. And so if you take a look here at this slide, we're just basically just reminding you in terms of ways to get involved with this community of practice. Don't forget to subscribe to the listserv if you haven't already. As we've already been talking, talk to us, send us recommendations, send us those success stories. Let us know what it is that you're doing in the field so that we can make sure to highlight all the many different perspectives and the diversity of work that we know is already going on, as well as some of the questions that are being raised. So Haley, I'm going to ask you if we just switch over to the video. I'm going to move over to Lindsay and ask, we have a video contribution from our colleagues in WHO Indonesia. And so we're just going to play quickly just another video just to let you know some other work that's going on.
So much for having me today. Thank you. Hello, everyone. Thank you for having me today. My name is Sukma Andrina. I'm Gender Equity and Human Rights Officer from World Health Organization, Indonesia. So today I am requested to share some of our experiences in integrating gender equality into our work in water, sanitation, and hygiene, or WASH. So we have been working closely with the government of Indonesia on WASH for some years now. But then in 2020, we saw the momentum of meaningfully integrating gender equality into the activities specifically on WASH in healthcare facilities. So it was during the pandemic, and healthcare facilities were under a huge amount of pressure to not only provide quality care, but also to keep the patients and healthcare workers safe. So at that time, we wanted to support the government to strengthen WASH in healthcare facilities by introducing the use of a WHO and UNICEF tool called WASH Fit, or WASH in Healthcare Facilities Improvement Tools. So WASH Fit is a risk-based management approach to improve quality of care through assessment of 7 domains of WASH in healthcare facilities, namely water, sanitation, hand hygiene, waste management, environmental cleaning and disinfection, energy and power, and management. So we rolled out the WASH Fit tools across Indonesia through a training of trainers. So the training represented an opportunity to also introduce the topic of gender equality and WASH to a wide range of participants from various organizations and government agencies that works with WASH. So during the training, we firstly had a session to sensitize participants on specific needs of women in terms of WASH due to events such as menstruation, pregnancy, safe toilet for heavily pregnant women, clean and hygienic maternity wards, personal protective equipment that accommodates specific needs of women, healthcare workers, and also women cleaners. And thereafter, we tried to integrate these needs into indicators in the WASH Fit tools together with the participants. So this would allow assessment of WASH services from gender perspectives, and also to make a gender responsive improvement plan and to track progress over time. And because this is a training of trainers, the participants were then expected to train healthcare facilities directly on the use of this WASH Fit tool, including to further sensitize and train the facilities on gender issues in WASH. And then later on this year, WHO was supporting the government in development of policies on WASH in healthcare facilities. And we saw this also as an opportunity to highlight gender equality issues in policy. So we wanted to provide clear recommendations in these policies on how to advance gender equality in WASH in healthcare facilities. But then to be able to develop these recommendations, we wanted to hear directly from healthcare facilities on their experiences in understanding and fulfilling the WASH needs of women. We then had a discussion also with a wide range of civil society organizations and development partners across Indonesia who work not only with WASH, but also with women's rights and children's rights about what they saw as challenges and best practices in integrating gender equality perspectives in WASH improvement efforts. And we finally presented this lessons learned from these discussions to policymakers, including Minister of Health, of course, and the recommendations from these discussions were then included in these policies, national roadmap and guidelines on WASH in healthcare facility. The recommendations include, among others, routine trainings on gender equality for all relevant actors involved in WASH issues in healthcare facilities, and then supporting research that explores specific WASH needs of vulnerable populations, including women, and innovative ways to address those needs, and also meaningful participation of women in WASH improvement efforts, from planning, implementation, to monitoring and evaluation. We still have a lot of homework to do, but we saw that the training of trainers and these focus group discussions and inclusion of recommendations in highest policies have indeed started the conversation on gender equality in WASH by policymakers, healthcare facilities, and all organizations who work with these issues on a daily basis. So that's our experience from Indonesia. Thank you so much for having me today. Thank you.
Great, and we're again so very grateful for that contribution from, again, our colleagues from WHO Indonesia. I am now going to transition us over to our just a wonderful panel that we've been able to really been very fortunate to have join us today. So I'm just going to go ahead and read out names and titles. We're not going to do biographies today, but certainly I will ask each panelist when we turn to you, if you just tell us just for a minute or two about your work and what your role is. And then what I'd like to do is really just launch into a discussion. And so what I'll do is start each panelist with a question. But then as they are talking through some of the responses and thoughts about these questions, we really do encourage you to go ahead and start putting into the chat or maybe raise your hand so that you can also have an opportunity to engage with our panelists. It's really the whole purpose of bringing this group here today is to have an opportunity to have a discussion. So please don't take the interaction that we're having here in the beginning that's a little more sort of formal to mean that you can ask your own questions because that's really sort of what we want to have happen here. So I will just go ahead and introduce that we have a panel that includes Brooke Yamagoshi. She's a WASH specialist from East Asia and Pacific Regional Office of UNICEF. We have Faustina Gomez, there you go, Brooke. Faustina Gomez, who's Technical Officer, Water Sanitation and Climate Change within the Department of Healthier Populations and Non-Communicable Diseases from the WHO Regional Office for Southeast Asia. There you have Faustina there. Then you have Christy Cade, who is CEO of White Ribbon Alliance. So you heard Haley make mention of White Ribbon Alliance within her presentation. So we're really excited to have Christy join us. And then we have Gloria Tokumi, Deputy Director of Clinical Information and Monitoring at the Ghana Health Services. And I believe Gloria is here. And we know that if you cannot hear us, Gloria, we're going to be working with you on the internet challenges you're having. But certainly we know that you were here with us. And so I will go ahead and start off with Brooke. A question over to you, that you have considerable experience in integrating gender into WASH programming, as far as we understand in your work. What barriers do we face when trying to integrate WASH and gender, particularly in the healthcare facility context? And what suggestions do you have for overcoming any of these hurdles? Of course, if you could respond to that question after giving us a little bit more about what it is that you do.
Great. Well, thank you so much, Joanne. And thanks to everybody who's presented and everybody whose work has been cited here. I mean, I'm really impressed by the work by WHO colleagues and others in Indonesia, as well as by the White Ribbon Alliance and the really impressive campaign and data that was shared. So I'm a WASH specialist with UNICEF's regional office based in Bangkok. It's our regional office for East Asia and the Pacific, where I'm part of my responsibilities includes WASH and healthcare facilities. And I'm also kind of our gender focal point, which is a role that I've had for a while now in a couple of different posts. And I think reflecting on the really excellent examples and very clear and practical examples, to your question about the challenges and how we can overcome these barriers, kind of reflecting on these, I think that it all comes back to power. And so I think it's really worth reflecting on power at the heart of these inequalities that we see in people's experiences of WASH services, as well as in the services that are delivered and whose perspectives are centered in service delivery. So, I would say that one of the biggest barriers is simply who has power and who doesn't. And the examples that Haley gave, the statistics that she cited of 75% of healthcare workers being women, but far fewer of the decision makers and people involved in resource allocation, maybe being women or having done these consultations, such as those that the White Ribbon Alliance did. I think that's an example of how power can be a barrier to ensuring that women and girls and men and boys have the types of services that are responsive to their needs throughout the life course. Many issues become marginalized because they affect those that don't have power, and therefore the sort of voices, perspectives, demands, and concerns of people that are marginalized are seen as being not relevant, or perhaps being infeasible or low on the priority list to address. So I don't know, we do a lot of consultations with girls and with women, and frequently some of these consultation exercises, such as asking girls to draw the sort of wash facilities that they would like at school or at a health facility or at their homes. I think those sort of consultations that can also raise the demands in a very practical and concrete way to decision makers to show how much girls and women are aware of their own circumstances, as well as the solutions that they would propose, can be very powerful. But very frequently, those same drawings can be pointed to and said, well, this is clearly very infeasible. This couldn't happen. It's not within our budget. Things couldn't be maintained like that in real life. So I think showing that these are not marginal voices, but indeed need to be centered in the discussion, is one very important aspect. And I think all of us as people that are working on improving WASH in healthcare facilities can use, our roles to help redistribute this sort of power through our work. So coming on to ways to overcome some of these barriers that I think have already been highlighted by others. So first, I wanted to talk more about consultations and consultations directly with women that fall into all three of those groups: patients, caretakers, healthcare workers. Patients and caretakers being kind of together, healthcare workers as the second category, and then administrators. So either directly consulting with them like the White Ribbon Alliance did, or working with CSOs that represent those groups. And I would also encourage us all to consider some of these intersectional aspects of gender and of women's lives. So looking also at women with disabilities, women with women that are also perhaps incontinent, meaning that they're not able to hold their urine or feces. So seeking out some of these other inequalities and looking at how they affect women throughout the life course. And then taking those consultations and giving, integrating them into, the different maybe building blocks of the enabling environment. So policies, financing, implementation arrangements, capacity, and monitoring, those five. I also wanted to say that these tools that I know WASH Fit was mentioned, the 8 practical steps, we'll be discussing that as well. Whatever tools we're using, you can always ask, where is gender in this, one element that we're going to assess, or where is gender in this tool, or how could I look at how I would ask this question or assess this element different if I were looking at the perspective of women or men or girls or boys. Then I would also say partnerships. So working with allies, whether they're from civil society or government actors or other groups from related sectors to ours. So protection, of course, gender colleagues, of course, WASH and health colleagues, but thinking about, who else could be an ally. And then maybe just coming back to these 5 building blocks. So first looking at policies, that includes standards and guidance. So making sure that all of our standards and guidance are gender responsive and women centered and informed by the voices of women in all of these different roles throughout the health system. Secondly, on financing, looking at resource allocation at all levels and how it's being used to benefit or maybe advance gender equality. So that's from the, national level all the way down to what's happening in facilities. And often what's happening in facilities is having the, is those micro decisions, influencing them can make a big difference. Third, on implementation arrangements, I think that's where, again, coming down to the facility level and looking on, on the ground, who's responsible for service delivery, who's responsible for operation and maintenance. I think, Haley mentioned cleaners, making sure that those roles and responsibilities are well allocated. Fourth, on capacity. So really some great examples from Indonesia, I think, on training and how different elements of the health system can be trained to ensure that services are gender responsive. And then lastly, on monitoring. And my last point might be about monitoring also, and how beyond just disaggregated data, we should really be seeking the perspectives of users to look at quality of services. Very frequently in the WASH sector, we're looking at outputs and we're monitoring outputs. So we're using access or the presence of a certain type of facility or service as a proxy for use or satisfaction. But I think we can do more to directly ask about satisfaction. Kind of last point on that is that I recall that last year, Lindsay had shared some data with me from, I think, Zimbabwe, where looking at coverage levels of both water, sanitation, and hand washing with soap and water available. So not only having one service, but in other words, having all three services together, I think was less than 3% of healthcare facilities. So I think, also that's an indicator of quality. And I would say, like, what other indicators of quality can we be routinely monitoring and reporting on that are showing how gender responsive we are? Thanks.
Great. Thank you so much, Brooke. Really thorough and comprehensive. So really grateful for just some of the concrete strategies that you provide for us. Again, I just want to remind everyone, as you're thinking and really mulling over all of what Brooke just shared, please feel free to go ahead and put your questions, thoughts, comments in the chat, as we are going to open this up to the larger group for questions later on. And so, Brooke, you touched on an issue I think that's really a great link to our next panelist in terms of thinking about intersectionality and thinking about gender and disability, or gender and some of the other inequalities that you mentioned that really affect women in healthcare facilities. And so I just want to turn to Faustina now and ask if you could, again, tell us a bit about yourself and your work, and then describe the toolkit that you are developing to augment the 8 practical steps, and how you anticipate partners and governments will undertake this process of integrating or mainstreaming equity for WASH in healthcare facilities. And I know we're focusing on gender, but I know there's some other elements that your toolkit touches on. So please, Faustina, go ahead.
Thank you, Joanne. And hello, everyone. I'm Faustina Gomez, and I'm the Technical Officer for Climate Change and WASH in WHO Zero. And I'm responsible for capacity building support and technical assistance to the member states of our region. And my focus area is WASH in healthcare facilities, among other things. And thanks for your question, Joanne. So let me start by giving you a little background on why we developed the toolkit. So while WHO Zero's, the WHO Southeast Asia region rather, performs better than the global average on WASH in healthcare facilities, particularly in the area of improved sanitation, we realize that improved WASH does not always translate to inclusive WASH. In the Global Progress Report on WASH in healthcare facilities, Fundamentals First, this was released by WHO in 2020, only 4 out of the 11 WHO Southeast Asia countries monitored whether they are even responsive to diverse user needs. So we realize that there is definitely a gap, and this gap is inclusive WASH can undermine the benefits of improved WASH. To achieve the full benefits of WASH in healthcare facilities, improved WASH should be accessible to all healthcare facility users, especially those with physical or mental disabilities or impairments, pregnant women, the very young or old, and those users who are unable to access hygiene information, say due to language barriers. And improved wash should also be acceptable by ensuring privacy, dignity, and the safety of users, and by giving, or rather by being culturally appropriate and sensitive to the user's needs and priorities. So the toolkit that Zero is developing on gender equality, disability, and social inclusion in WASH and healthcare facilities, it provides a step-by-step guidance on how countries can integrate GEDC. Like I mentioned before, GEDC is gender equality, disability, and social inclusion into their strategies and activities for strengthening WASH and healthcare facilities. The steps are aligned to the 8 steps described in the WASH and healthcare facilities practical steps to achieve universal access to quality care. This was developed by UNICEF and WHO in 2019. Now, each step in the toolkit has case studies from the region and tools to support GEDC integration. Most of these tools are drawn or adapted from existing material that focuses on GEDC and WASH. And also, just as in the 8 practical steps, the 8 steps in Zero's GEDC toolkit, they're also presented in a linear fashion, although action can occur in just about any order or simultaneously. For example, step 1 to 3, it involves national level preparation and the creation of an enabling environment. And step 4, 6, and 7, it has its focus on facility level implementation. And steps 5 and 8, it involves all levels of monitoring and documenting what works. The guidance also supports GEDC integration into the WASH Health Facility Improvement Tool. The toolkit provides a background of the population groups that are often marginalized, a summary of global commitments, along with easy to use and interactive and adaptable tools for each of the 8 steps. We believe that these tools will help WASH practitioners in integrating GEDC in WASH and healthcare facility programming. That's it for me. Thank you so much.
Great. Thank you so much, Faustina. You know, I think what you have raised is really, again, it's so very nice that everything that you're sharing, and certainly what Brooke started out with, really links very nicely to our next panelist, Christy Kay, when we start talking about sort of quality and what is it that women want. And so I'm going to turn to you, Christy, and ask that we know that your What Women Want campaign found WASH to be the #2 ask of women and girls for quality healthcare. With this in mind, what are you now advocating for, and what do you hope that the WASH and healthcare facility community can do better to support quality healthcare for women and girls? Christy?
Yeah, thanks, Joanne. And thank you so much for having us here. And thank you, Brooke and Faustina. I was taking lots of notes during your talking points, because I see lots of points of intersection. For those of you who are maybe just a little bit unfamiliar with White Ribbon Alliance, we are a global network dedicated to improving the health and well-being of women and girls around the world. You know, we do this by aiming to activate sort of a people-led movement for reproductive, maternal, and newborn health and rights. And sort of when we were founded sort of 20 years ago, the reason we were founded is because we found the voices of women and girls were actually being left out of discussions on maternal health, you know, causing really slow and inequitable progress in different country contexts. And I would say, well, a lot has changed in 20 years. Unfortunately, that still does remain the same. And so that's what really led us to creating the What Women Want campaign, which, you know, began with a really simple idea. You know, ask those who most use health services what they most need. You know, ask clients, ask the women and girls. Julian, I think I'm going to try to back into your question a little bit. And I first just really want to make the point that policies and programs look very different when they are shaped by country leadership with global players, as opposed to when country leadership shapes them with their people. And to kind of highlight this, I want to give a very specific example from Niger, state Nigeria, where WASH was in fact the #1 demand of women within that state as part of the What Women Health campaign. There's the Basic Healthcare Provision Fund, which I'm sure many of you are familiar with. This fund, which was dedicated to improving primary healthcare quality of primary healthcare, had been sort of celebrated as a concept on many global stages for years. I think I first heard about it 6 years ago. But it was essentially dormant in Niger State until last year, when local women and girls really started rallying for it and offered decision makers a clear path on how to spend it. It was last year, for the first time, funds were finally released from all 274 primary healthcare facilities within the state. Now, what I think is one of the most exciting things is 10 of these facilities, and some of the most remote locations in Niger State, some of the most rural local government areas, were installed with running water where they didn't have any before. And this is because this is what women and girls were demanded. And those facilities benefited a service population of over 400,000 people, more than 5 times those who actually participated in the original What We Want campaign. And they also made a change that to be designated a primary health care facility, you needed to have 6 working, functional, safely managed toilets, 3 for women, 3 for men, addressing major issues of sanitation and personal security that was being spoken about earlier. So why this happened, especially during COVID, when we know there was so many competing priorities and interests, was that women's voices really were able to kind of raise above the din, raise above the special interests that were actually serving to stall progress on the basic healthcare provision rather than advance it. And this water win was really co-celebrated by women and girls and decision makers in Niger alike. It was something that they really felt they did together. I have to share, though, that it was not celebrated in all corners of development. In fact, I was advised to leave it out of a report to a maternal and newborn health donor. Higher-ups within that agency were frustrated that What Women Want was serving to elevate WASH and healthcare facilities as a maternal health issue, and were frustrated that it was at the expense, in their mind, of more focused interventions on like kindergarten mother care or group A and C. They said it was embarrassing that women and girls were asking for such basic things as toilet and clean water. And I agree, it is embarrassing. It's embarrassing that women and girls are continuing to ask for these things, and we are continuing to ignore them to the point it's being asked to be omitted from a report. And I do want to say, I do not diminish those types of interventions. I believe in them and I advocate for them. But ultimately, I think we are really accountable to women and girls. And I ask us all, how can we have a real serious conversation about preventing maternal death and illness if the facilities where women are giving birth don't even have running water where they can wash the blood off themselves after they give birth? You want a woman to practice kangaroo mother care or attend group A and C sessions? I think we need to show her we're listening to her, and she might be more inclined to listen to us. So back to the question at hand from Joanne. What do I think the WASH and healthcare facilities community can do to better or differently? Well, I think the last year has really elevated vital conversations on decolonization and power within the health and development sector. And as part of that, the first thing I think we need to do is shine a light on these tensions and issues. The irony, we're an advocacy organization, and we are often granted by donors and multilaterals to advocate on an issue that's being made more difficult by another section of that same agency. I also think we have to, call out and not be easily assuaged from answers from donors and global groups about WASH and healthcare facilities being handled by someone else, somewhere else. That is marginalization. This is an everyone, everywhere issue. And issues and people are marginalized because people in power marginalize them. They can also unmarginalize them. I also think we need to be really honest about the limits of evidence-based advocacy and decision-making. Data is an easy excuse sometimes for inaction, especially in rights issues. And I think I want to be clear that WASH in healthcare facilities is a human rights issue, as often as it is a reason for intervention. And I am all for evidence. And let's be clear, there's tons of evidence out there supporting WASH in healthcare facilities. But I think there's often a pick and choose about which data is used to inform decision-making and prioritization. And I think we all know so much of the data that is used and referenced in our circles drips with power while claiming objectivity. Again, some of the most powerful data in decision makers' eyes is what their constituents are asking for, but we continue to not invest in that. So again, all of this said, I still think in general, we spend way too much time talking at the donor and multilateral level and to each other. You know, advocacy efforts are focused on global database and WHA resolutions that reach a relatively small circle and community of technocrats, development partners, and civil society actors. We need this issue to go to the politicians and to the people. Enduring commitment and accountability for women's health and rights and WASH in healthcare facilities as part of that, I think will only become at the behest of the country's people. Now, really, no social movement has successfully transformed its society without large-scale demand from citizens and communities. Now, this is not really a matter of the latest technical intervention or innovation. We know it works. It is a matter of will. It's a matter of political will. It's a matter of the people's will. It's a matter of valuing women, not only their lives, not only them as mothers, you know, having a safe pregnancy outcome, but it's valuing their opinions, their ideas, their solutions, their voices, and their power to make change. And so I think the Washington healthcare facility community needs to be investing in them more and more.
Wow, that's all I can say, Christy. You have certainly brought some points here that is really shaking us up and really forcing us to think about when we say community-centered, what are we talking about? Are we really doing that work? Which is, again, part of the practical steps to engage the community. But I really am so very grateful for your perspective and thoughts on this. And again, I encourage you all just to comment and react to this whole, just the summary and really just the position that Christy has raised here in terms of what are we doing, how we use data, are we using the data? I mean, this is really just an important perspective for us to hear and think about when we really start talking about what women want. And I mean, such powerful statements about they keep asking and we keep ignoring and going on to other things. And it's time for us to stop ignoring what is right in front of all of our faces. So thank you so much for sharing your thoughts. And really now I'm going to turn to our last panelist, Gloria, who's coming from the sort of the national health system perspective with Agana Health Services, and just really implore you to tell us more about what your work is. And then thinking about the national health system workforce, you've seen policymaking firsthand for Washington healthcare facilities. What are your biggest concerns as relates to gender responsive services and what's not being provided? And how can female leadership impact the provision of these services? Again, just playing off of everything we've already heard, sitting within the government sort of area. What are your thoughts about this, Gloria? If you can hear us, hopefully, Gloria. I don't know if Gloria is with us and is able to unmute.
It looks like she was just on and maybe just popped off. So maybe she's rejoining.
Okay, we do know that Gloria is having a bit of difficulty with internet today, so hopefully she'll be able to come back on. So in the meanwhile, what I'll do, again, just to keep us moving forward, because I do want to get to a space where before we end, we give the community that's gathered here an opportunity to ask some questions. But I do want to ask one last question to the panelists before we move on. If everyone could just really think about, what is the one action? And I know many of you have already sort of outlined different strategies and just really sort of a list of things that could be done. But if we were to think about tomorrow, what is that one action that partners could take in seeking to make their wash and healthcare facility programs and policies gender responsive? What could they do tomorrow based on your perspective to begin to make that happen? So again, I'll go back to the beginning. Hopefully Gloria will join us. Brooke, if you could take a moment and just sort of share with us what you think would be that low-hanging fruit first steps.
Great. Thanks, Joanne. So maybe, and some great reflections from Faustina and Christy. I mean, really powerful, very practical. I would say tomorrow, so just to give a very quick answer, and I also have some thoughts on what's in the chat box. But, tomorrow, the best thing all of us can do is look internally, I think, at ourselves and at our own assumptions, at who's represented on our own teams, and at whether we've taken these basic steps of consulting with, the perspectives of women and men in different parts of the healthcare system, talking to, girls, of talking to women from different marginalized groups, and whether in the type of support that we've been providing, to governments, to other service providers, whether we've been intentional about, being gender responsive and being responsive to many of these other inequalities, or trying to, eliminate these inequalities. So I think that, maybe that's the first, very, assuming that, you can't organize a consultation or do a full policy review with the expertise that you might need tomorrow. Tomorrow we can all maybe look internally and start with ourselves. Thanks.
Great, thank you so much, Brooke. Could we have Faustina comment?
Thanks, Joanne. And I guess I agree with Christy and Brooke, and what I would recommend is advocacy at the highest level as a first step. We need to ensure that we have sufficient ownership at the highest level to take the agenda forward, and to ensure that priorities are accorded to resource allocation for integrating gender or GEDC in wash and healthcare facilities. For this, I think what's important is engaging the healthcare facility users whose needs and priorities are or have been neglected, and advocating for inclusive wash and healthcare facilities. So that, I guess, is the first step.
Great, thank you so much, Faustina. And Christy, if you could share with us.
Yeah, I think there's a lot of synergies and themes between what myself, Brooke, and Faustina has said. I really want to also pick up on something Faustina said in her first presentation about inclusivity, and then what also Brooke said about just looking internal and holding the mirror up. To me, being gender responsive means being responsive to women and girls in all their diversity, and so I think it also really means tackling the issue of ableism, and really kind of focusing on that. I think women with disabilities, especially, they suffer at the hands of health systems that were never designed to accommodate them, or have no real understanding of sort of the unique circumstances of their lives. And, earlier I celebrated that win in Niger State about the primary healthcare facilities having 6 bathrooms, 3 for women, 3 for men. But were those designed ever in mind about what it means to be 9 months pregnant and trying to actually go to the bathroom and use those, let alone being a woman with a physical disability, and how to use that? I think, and I'm saying this because WRA has been guilty of this too. Too often I think health systems devalue the perspectives of women, and particularly those who are living at the margins. I think we're confident and our own technical expertise, or that we know what the barriers are or the motivators, and why waste the time doing that? But you know, I think it's those things are always dynamic, they're always changing, and I don't think we have a real appreciation of, you know, how ethnicity, class, gender fluidity, sexuality, and disability all really influence sort of women's and girls' wants and needs. I know what ribbon we did the What We Want campaign, but it really was targeted at general population. And when we did do some, you know, analysis that's even a smaller survey, it shows the very specific divergence somewhat and what women and girls are asking for based on, you know, these different characteristics. And so I think we really need to value, you know, more different types of knowledge and expertise, first and foremost, the kind that really comes with lived experience. And so, you know, I recommend we all sit down with women and girls, and especially those with disabilities, and really listen to them, you know, and ask yourself, when was the last time you actually did that? And did it at any sort of, you know, form of scale? It goes without saying that I think, you know, women and girls know better than anyone what is going on, what is needed to improve their own health and well-being. And, you know, the fact remains that despite decades of effort, we are still not reaching that last mile. And I believe the answers really do lie with women and girls, particularly those who often go unheard. I think if we place them at the center of care, support them to have more say and control of health services and health outcomes, we actually will build a more equitable and better health system for all. So the one takeaway, sit and listen to women and girls and do what they tell you.
Thank you so much, Christy. Again, we're having trouble still connecting Gloria. And so what I'm going to do is go ahead and open up to some questions that have been raised through the chat. And so we're going to just go in order of the way they were coming in to the panelists, or if there are other people in the community who could respond to this. So one of the questions, are there indicators already defined for taking gender into account for Washington healthcare facilities? Does anybody have any insight on that? And does our silence speak volumes as far as the kind of indicators that we're developing and working on and working with?
Maybe Joanne, I can jump in here. I think that our silence speaks volumes. I think, you know, frequently we are monitoring the presence or absence of facilities, and then some aspects of, you know, those facilities, you know, whether they're available at all times, where they're located, you know, those sorts of things as a proxy for, you know, what level of service is being provided. And I think that, you know, we're not often looking at the experiences or the satisfaction of, you know, in a way that could be disaggregated meaningfully for not only gender, but also other factors like, you know, age, ethnicity, or other things. So I think, you know, frequently we're focused more on the thing, maybe, than the patient. But I know that some of the indicators that are already, you know, widely used, I think somebody put in the chat about monitoring, you know, aspects related to menstrual hygiene management, you know, those aspects generally affect women and girls. So, you know, I think you can get some data from those, but I would be super curious to hear from others of what they found that works well, or how they're monitoring this.
Mm-hmm.
And I might just add, I totally agree with Brooke, and, you know, defer to her as the expert in this space. But one thing I think is still a challenge when it comes to indicators and how we approach monitoring evaluation, a lot of time what we want to measure is not what's important, again, to women and girls. And, you know, and so I just think, again, we need to expand that idea of, you know, really sitting with women and girls to the idea of monitoring and evaluation, and even developing indicators in conjunction with that, because I think that's also something that's been really lacking in our larger industry, and how we actually even look at accountability on whether we're making true progress. We're not really often looking at that impact, and very specifically how women and girls are experiencing the changes that we think we have the measures saying that they should be within their own daily lives and their backyards. So again, I think there's that consultation piece. I think we can do a lot more on monitoring and evaluation that builds that in collaboration with local groups and partners and communities themselves. Very often, so much of M&E is kind of
Coming in.
very top down, put down, and I think in that way it doesn't often speak to really what are the issues always that do need to be addressed.
And excellent perspective. Thank you so much. I see Dr. Bhatia has her hand up. Would you like to unmute yourself?
Good evening, Lindsay and Denny and all the panelists. Thank you so much for such a wonderful, enlightening discussion on the gender responsive care. Just wanted to, flag a few points which were very similar to the presenters. When we monitor the wash and health interventions in the labor rooms, at the facilities, or where the girls and women are using the facilities, it is always a challenge to prioritize funding for operations and management of the functional facilities. And the second important area that we face as a bottleneck for us is when we talk about menstrual hygiene management per se. One part of it is about, ensuring that a toilet facility is functional. But the other part of it is also how to dispose safely menstrual hygiene products. So this is one challenge in a labor room. We've been trying to advocate for, incinerators, low-cost incinerators at health facilities, but those also have challenges of, pollution control and approvals from the Pollution Control Board. So if there are any examples from any other countries, it would be worth sharing as to how we can also look at, safe disposal of the hygiene products, and also educating the community and the women and girls on to safely dispose them. Thank you.
Thank you. Thank you, Vandana. What I will say is that I think we have Gloria who is with us. Gloria, can you hear us?
Yes, I can hear you.
Perfect. So in the few moments remaining, Gloria, we just would like for you to tell us a little bit about your work, and if you could respond to the question around the fact that you've been involved with Washington Healthcare Facility policymaking. What are some of your concerns about not providing gender responsive WASH services, and how can female leadership impact the provision of these services? So please go ahead.
Yeah, thank you very much for involving me in this section. I'm very grateful to be part of this. The biggest concern in this area is that most of the time, policymakers and managers are not well informed regarding issues with gender. And so we need to involve and inform policymakers, managers, researchers, and all stakeholders in WASH for them to be very much sensitized and informed of issues regarding gender, especially in WASH. And so when we are informed, then we will know which direction and what to make, especially even women group. I always ask myself, women groups or women leaders, are we well informed when it comes to gender issues? What do we really want when it comes to healthcare facility WASH? And so we need that exposure. We need to know more about issues regarding gender. And then once we know about it, then we'll talk about it. Then we'll make noise about it. We need advocacy in that regard. We need people who will be advocates of gender so that we have issues, or we are well versed in issues regarding gender. And then also stakeholder involvement, stakeholders in WASH, the integration that we need in WASH. We need people who are also knowledgeable and well informed in gender inclusiveness, so that we will all be a part, and then policymakers will also know about it. I'm very, very much happy when the other presenter talked about data. What do we have when it comes to gender in WASH? We don't have any data to inform us. We don't know much about it. We don't gather information regarding gender. We have a lot of vulnerable members in the group. We have women who need, we have disabled, we have children, and we have other people in need that we need to look at. But when we talk about it, where do we, what basis, on what basis do we talk about? We need to get information. We need to have some tangible information on it so that we can use it to make noise, and we can also use it as policymakers and as managers to base some of our decisions on. And so data is very, very important. And then also we need more information in that through research also. So we need to also do research in that area to get more information that will inform us on the next course of action. There are a lot of challenges when it comes to WASH regarding women needs and things like that. We mentioned some of the things, menstrual hygiene and the others. And then also women are the ones who go fetching water and the thing. Do the people who are even involved in this, do they know much about it? Health workers themselves need to be informed. They need to know about it. And then also, once we know about it, then we'll be able to integrate some of this and then go do more analysis, gender analysis, and integrate some of this into our program. And that will help us to be able to make policy for implementation, and even put it into some of our regulations so that we'll be able to enforce and implement it. And also there's a need to also develop a sensitive, gender sensitive M&E programs, so that whatever activity that we've done, WASH programs that we've done, we'll be able to monitor it and see whether we have involved or we have included gender programs that will be able to support the vulnerable in our activities. And so in planning, in developing our policies, in our target setting, we need that, we need gender.
Oh, I think we are unable to hear you anymore. Unfortunately, I think we may have lost Gloria again. That was Gloria To Kumi, the Deputy Director of Clinical Information and Monitoring with the Ghana Health Services. Again, she's having
objectives to be able to
Gloria, if you can repeat yourself, Gloria.
We don't provide them. And so
Gloria, can you just,
hello?
If you can just pause for 1 minute. Unfortunately, we lost part of your statements because of the internet. If you can just go back a minute or so as we try to wrap up, if you could just go back a minute and start over. We weren't able to hear you.
I don't really know where exactly you mean.
Yeah.
And so what I'm saying here is that we need to sensitize people. We need people who be advocates for gender inclusiveness in our health programs, particularly when it comes to WASH in healthcare facilities. We need researchers who will generate interest. We need data where, that will help us to base some of our decisions when it comes to gender inclusiveness in WASH. We need data on that. We need to collect data, baseline data on our current situation, and then where we want to, our projections, where we want to, so that we'll be able to base some of our decisions on that data. And then also stakeholders in WASH. We need to sensitize stakeholders so that when we are integrating them, because I mentioned that healthcare facilities are the end users. We use the amenities that have been provided. We don't provide water services. We don't provide sanitation services. And so when it comes to provision of such services, the implementers, those who provide them, they need to be involved. They need to be knowledgeable in gender sensitive issues, so that in their planning and in their implementation of their programs, they will be able to look at that regard, to be able to provide those services for healthcare facilities. I guess you hear me now.
Yes, we can hear you. Thank you so much, Gloria. We're so very pleased that you were able to come on and share your thoughts. I feel like you essentially summarized all of the discussion that we were having prior. So again, thank you so much. You touched on so many of the same themes of inclusivity, being informed, using data, not just collecting it, using it, but then also grounding our work within the community and no longer just sitting in our chairs and making decisions, but certainly hearing the voice of those who are actually in receiving services and working in healthcare facilities. So we thank you so much. And because we're very, very close to the end of time, I'm going to go ahead and pass it on to Lindsay, who has 1 or 2 minutes of just some additional thoughts for us. Thank you to all of our panelists. We're so very grateful for you all who were able to stick with us for this hour and 15 minutes. And again, I'll pass it over to Lindsay to close us out. Thank you, sir. Thank you again.
Great, wonderful. And thank you to all of the speakers here. We like to leave with actions. So I'm going to highlight key actions I heard. I heard our panelists putting us to task to look internally at our assumptions, to advocate at the highest level, to sit down and listen to women, particularly thinking across the equity spectrum and thinking about some of this intersectoral work. And then also looking at our leaders, ensuring our leaders are sensitized, informed, and we're really collecting enough information to be able to do gendered analysis and understand the gaps. And certainly I think there are some questions in the chat about power dynamics. I think there is more work to be done on that. I didn't have a great example to respond to in the chat about how we convince leadership to consider taking more of a gendered approach. So I encourage all of you to be documenting your work on this. I think it's fantastic to hear about all that's happening. You heard the WHO case study at the start, but if you all are doing this work, please, please, please be writing this down, sharing with your colleagues, because that is really where the learning comes from. So just a quick note about next steps. We are meeting next live in February. We'll have a live session. This is a bi-monthly event with the community of practice. I believe we'll be talking about some interactions between behavior change, communication, infection prevention control, WASH, and COVID. And again, we can think about how female workforce and cleaners are a big part of this. So certainly we'll make sure that we're doing our own due diligence, that gender is part of these sessions and holding ourselves accountable. I do want to note that our website is ready and we're getting it up and running. So washandhtcf.org/COP, Community of Practice. If I quickly share the screen here, sorry, I'm on 2 computers right now, doing this in multiple languages, but it looks like this. And so this is going to be the community practice website that will have all of the resources, all of the recordings, information about the next events, etc. We also will be sharing in off months, we'll be sharing with you all short videos. So Joanne and I have to sit down in January and get you all a little short 5 to 7 minute videos that really get to the heart of these issues and start some discussions and get us ready for live events. So that's where I'm going to leave you all today. Super appreciate everyone coming on. I need to look through these chats because I think there's a lot of unanswered questions, which to me speak to the more work that needs to be done on gendered responsive WASH and healthcare facilities. So have a wonderful rest of your week. Happy holidays to those who are taking off, and we will speak with you again live in February. But look out for your newsletter, and I'll be sending around the link for the website imminently. Take care.
Thank you, everyone. Have a great evening, afternoon, wherever you are.
Yeah. Thank you.
Happy holidays. Yes. I see.
Thank you. Thank you.
Happy New Year. Yes.
Thank you.
Bye, everyone.
We'll keep it open for just a second. If there's any more chats, feel free to drop that in there, and I will do more research on what is and isn't being done. Thank you to our wonderful speakers. You all were fantastic, and we really
fantastic. Thank you, panelists.
I didn't say that earlier. I'm so sorry. Thank you, interpreters. You're fantastic also.
Yes.
I will go ahead and close it in just 1 more minute. So. All right, we're gonna go ahead and start closing things down. I'm just gonna close out the room individually, and then Haley, if you don't mind staying on with Joanne and I for just a minute.
Sure.
All right, thank you all. Have a good rest of your day.
Lindsay, if you want to cancel translation too or interpretation, we can let the translators go. Thank you guys so much for interpreting and joining early.
Thank you. Goodbye.
Thank you.
Thank you so
Bye.
much. Thank you.
Thank you all. See you. Bye.
And if you want to help me take people out, that would be great.
Right. Let me switch my view. I'm still looking at speaker. Let's see.
All right, and I will stick.
Oh,
Yeah. Like, who's this Neely person? Oh, yeah, right.
who's that?
Hold on, I'm just gonna turn on our waiting room 1 second.
And is our recording off?
Yeah, I'll stop it right now.
I'm just gonna, my other person's gonna leave.
That's fine.
Okay.
Hold on, I have to stop.
It's